Assalamu alaikum everyone. My name is Abdulrahman Alkhatib. I'm a third year medical student. Today, inshallah, I'm going to be explaining a very easy lecture about large intestinal motility. And for the sake of the flow of the lecture, I have divided it into 5 different objectives. And starting off, so whenever we talk about the large intestine motility, we have to think about 2 types of movements that happens there. The first one is called the haustral shuttling or the segmentation. The other one is called the peristalsis. Now, regarding the haustral shuttling or the segmentation, the key thing here is that it's a segmental type of contraction. Now, that means that it's not designed to propel the food all the way to the rectum. Instead, its main job is to increase the contact of the feces with the mucosal wall, and this will in turn enhances the absorption of the electrolytes, of the water, of the minerals, as well as some other vitamins such as vitamin B. So remember, the main purpose of the haustral shuttling is absorption. Now, regarding the peristalsis, those are much stronger contractions that propel the food to the rectum. During mass movements, they are usually initiated by the gastrocolic reflex as well as by the gastroileal reflex. Now, one key feature that differentiates these 2 types of contraction is that the haustral shuttling is dominant in the ascending and in the first half of the transverse colon, while the peristalsis is dominant in the second half of the transverse colon as well as in the sigmoid colon. Now, the peristalsis usually happens quite a few times a day, usually 1 to 3 times in a normal individual. So that was just a brief overview. Now let's take a deeper step by exploring the haustral shuttling. So, can you see those haustras? So those haustras, or those little pouches or sacs, are formed by the strong contraction of the circular smooth muscles. Now this contraction have divided the lumen into these segments. Now, compared to the segmentation of the small intestine, those contractions are slower, but much stronger. Now, what's important to note that these contractions are dynamic. That means that they are constantly forming and reforming, which allows for maximum absorption and efficient mixing. Now, you may question why in the segmentation, the chyme can move back and forth. Now, the reason is we are not interested, as we have mentioned, we are not interested in pushing the chyme to the rectum, right? We are interested in the absorption. So this back and forth movement will ensure efficient mixing through mixing the chyme with the digestive enzymes, some pancreatic enzymes, as well as it promotes better contact of the feces with the mucosal wall. And lastly, it's going to slow the forward movement of the chyme. So the segmentation will mixes the chyme, promote the absorption of the electrolytes and water, and will also slow the forward movement of the chyme. Now, one key feature that differentiates the small intestine from the large intestine is that the large intestine lacks proximal to distal basal electrical gradient. And this explains why the frequencies or the slow waves are highly variable depending on the region of the colon. Now, as you can see here on the slide, the ascending colon, the cecum, and the sigmoid colon, the lower frequencies dominate there. The transverse and the descending, we have a bit higher slow wave frequencies, around 11 cycles per minute. In the rectum, we have the highest slow wave frequency, around 17 cycles per minute. And this should make sense to you guys because, as we have mentioned, in the ascending colon, cecum, first half of the transverse colon, we are mainly interested in mixing the chyme, right? In absorbing the nutrients, absorbing the water. And this absorption needs time. That's why the slow wave or the lower frequencies dominate there in this region. However, in the second half of the transverse colon, in the descending colon and the rectum, we are mainly interested in propelling the fecal material all the way down there. Now, if we have decreased motility, that means that we are increasing the absorption of the water and we may end up in a constipation. On the other hand, if we are increasing the motility, that means that we are decreasing the absorption and we may end up in a diarrhea. And both of these is not good. So the key here is to maintain a balance between these 2. Now, as you can see here, in the first part of the large intestine, the chyme was kind of fluid, turned into mushy, semi-mushy, semi-solid, and then at the end, solid feces. Okay, so as we have mentioned, the cecum, ascending, and the first half of the transverse colon, those sites are the major sites for the absorption of the fluid and electrocytes. And this should make sense because which type of movement dominates in these regions? The answer is the segmentation, right? Or the haustral formation. And what's the main purpose or what's the main reason behind the haustral formation? Is the absorption, as we have mentioned, right? And in the second half of the transverse colon, descending colon, the rectum, the mass movements or the peristalsis dominates there. And this is what pushes the fecal material all the way down. Sometimes the propulsion are so strong, usually more than 20 centimeters or even more. So very huge differences covered by these mass movements. Now we mentioned this many times, but the segmentation or the haustral formation is mainly dominant in the ascending and the first half of the transverse. The peristalsis is mainly dominant in the other half of the transverse as well as in the sigmoid colon. So this is very important. Now let's talk about the peristalsis or the mass movements. We said that those are much stronger contractions and they propel the fecal material down there into the rectum. And they are mediated by our long reflexes mediated by the autonomic nervous system. And this is very important and you should guys focus. So the mass movements are triggered by meals. So first of all, when we eat meals, the meals will initiate a gastrocolic reflex. And this gastrocolic reflex will initiate the mass movements. Tamam? So here I have a simple diagram written below. So as you can see here, the meals will trigger the gastrocolic reflex, but also the meals will trigger the gastroileal reflex. So when we eat meals, the meals will trigger the gastroileal reflex. And what does the gastroileal reflex do? It will push the remaining material that was in the ileum into the cecum, right? And the gastroileal reflex, this movement of material from the ileum into the cecum, will enhances the gastrocolic reflex. And at the end, we are having mass movements. So the mass movements are triggered by the gastrocolic reflex mainly, as well as it's triggered by the gastroileal reflex, but it's like indirect pathway. And we said that when we eat meals, the meals will trigger the gastroileal reflex. The meals will also trigger the gastrocolic reflex. And the mass movements, the main purpose of them is to push the material from the transverse colon into the rectum for the defecation process to take place. Now, those are X-rays of a patient who have ingested barium, and the barium lights up in the X-rays. So those images represent different timings. First of all, we can see the shadow in the terminal ileum, cecum, and part of the ascending colon. Now, after the patient have ingested a second meal, so the trigger is the meal, right? We said that the meal will initiate both the gastroileal and the gastrocolic reflex. And we said that what does the gastroileal reflex do? It will push the material that was remaining in the ileum into the cecum, right? But also after that, we have the gastrocolic reflex, and we can see here the material in the transverse colon, splenic flexure down there to the sigmoid colon. So the mass movements that have pushed the material from the mid-transverse colon all the way to the sigmoid colon or to the rectum was initiated by the gastrocolic reflex. And the gastrocolic reflex is triggered by meal. Now, at the end, we have the fecal material accumulating here, downward in the sigmoid colon and in the rectum, and distension of the rectum will trigger the urge to defecate. So that was it, and this basically the same slide, just shows different timing. Now, moving on to the rectal motility. First of all, we have the internal anal sphincter and the external anal sphincter. Now, the internal anal sphincter, as you can see it here, it's made up by circular smooth muscles, and it's under our involuntary control. Now, the external anal sphincter is a striated muscle. It's a skeletal muscle, okay? And it's innervated by our pudendal nerve, by somatic innervation. Now, both of those sphincters remain constricted. However, when the rectum is distended, so when the rectum is distended, about 25% is filled. This will trigger the air certificate. So as we have mentioned, the mass movements will push the material into the rectum, and when 25% of the rectum is filled, this will trigger the air certificate and go to the restroom. Now, if the defecation process cannot happen at this moment, if the defecation process is inconvenient, our body has developed two main mechanisms to delay the defecation. First one is the accommodation. The second one is the retroperistalsis. Now, in the accommodation, the smooth muscles of the rectal wall has a unique property called stress relaxation. It's called stress relaxation. This means that even though the rectum is stretched, the muscles will gradually relax in order to lessen the air certificate. Now, the second thing is the retroperistalsis. Now, what does the retroperistalsis do is that it will push the material from the rectum into the sigmoid colon, allowing for temporary storage. Now, the retroperistalsis have two advantages. First of all, it can push the material, as I have mentioned, from the rectum into the sigmoid colon, promoting a temporary storage of the fecal material. Second of all, it's useful for those type of drug delivery, the suppository drug delivery. And in this type of drug delivery, it has some advantages because it's delivered via the anal canal. But anyways, you guys don't have to worry about them. You'll take them in the POD block next year. But remember, retroperistalsis will push the material into the sigmoid colon. And it's also useful for this type of drug delivery. Now, I want to mention a thing. If you ever sometimes drink coffee on an empty stomach in the morning, after like a very short period of time, you feel the air certificate, right? Now, what happens is the stretch receptors in our stomach will senses the content, and this will activate the gastrocolic reflex. And we said that the gastrocolic reflex will trigger the mass movements. The thing that happens is that we want to empty or clear up the space for the upcoming contents or the upcoming meals. Tamam? So, in response to rectal distension, three things that happen. They are very important. First of all, the rectum contracts, the internal anal sphincter will relax, the external one will contract. Now, as you can see here on this diagram, first of all, there was passive filling of the rectum. طيب? So, fecal material have accumulated, and at a certain point of time, around when the rectum is filled about 25%, the rectum will actively contract, and this active contraction will make the pressure go this high. Tamam? So first of all, there was passive increase in the pressure in the rectum due to the accumulation of the fecal content, but then there was active contraction of the rectal smooth muscles, and this have increased the pressure a lot. Now, secondly, in response to defecation, the internal anal sphincter will relax, and it's demonstrated by this graph right here. So the internal anal sphincter will relax, mediated by our enteric nervous system. The enteric nervous system will release the nitric oxide and the vasoactive intestinal peptide. Remember this. The external anal sphincter, which is under our voluntary control, will contract in response to rectal distension, right? So the external anal sphincter is innervated by our somatic innervation via the pudendal nerve, and this will contract, as you can see it here on the diagram. And as the pressure of the rectum increases, the external anal sphincter pressure will also increases. So as we have mentioned, the external anal sphincter will contract to delay defecation and relaxes to allow defecation whenever it's convenient. Of course, it's under our voluntary control. Now, the defecation process involves two main action or two main controls. The first one is the intrinsic reflex. The second one is the extrinsic or long reflex. Now, as the fecal content is accumulating in the rectum, it will distend it. So the rectal distension will inhibit the internal anal sphincter. However, the intrinsic or the short reflex, it's not that strong. It's not the whole process of the defecation. So there has to be some extrinsic long reflexes. Now, part of the extrinsic long reflex is mediated by our lifesaver, is mediated by our pudendal nerve, which innervate the external anal sphincter. So, if it's convenient to defecate, we can relax the external anal sphincter and allow the full process of defecation to happen. If not, it will remain constricted, allowing for the accommodation of the continence. Now, as I have mentioned, the defecation reflex involves the intrinsic or the short reflex as well as the extrinsic reflex. Now, the intrinsic reflex is mediated by our enteric nervous system, as I have mentioned, via releasing the nitric oxide and the vasoactive intestinal peptide. And the intrinsic reflex mainly relaxes the internal anal sphincter. But we also have the extrinsic long reflex. As you can see it here on this diagram, this is the extrinsic long reflex. First of all, we have the afferent fibers coming from the rectum into the spinal cord, and they will give me a set of efferent fibers via the pelvic nerves. Okay, so the efferent fibers via the pelvic nerves will enhances the peristalsis of the rectum and will also causes further relaxation of the internal anal sphincter. But also, as I have mentioned, we have our best friend, our lifesaver, which is the external anal sphincter. So we have another set of efferent fibers, but this time via the pudendal nerve. So the pudendal nerve fibers will innervate the external anal sphincter, allowing for the voluntary control over it whenever the defecation is voluntary, whenever the defecation is convenient. Tamam? Now, 3 players that is involved in this process. Remember, the enteric nervous system, the parasympathetic nervous system, and the somatic nervous system innervation via the pudendal nerve. Notice that I have never mentioned sympathetic nervous system. So sympathetic nervous system do not contribute to this process at all. Now, there is one muscle in our body which is called the puborectalis muscle, and this muscle plays a very crucial role in maintaining the continence or the defecation. So, at rest, when we don't want the defecation process to happen, this muscle remains contracted, and it's forming, like you can see it here, it's kind of sling, right? And this contraction will make this sharp anorectal angle. So as you can see it here, this anorectal angle. And the reason behind this is that it will allow the accumulation of the fecal content here. Now, during the defecation process, let me highlight it here. So during the defecation process, this muscle will relaxes and this will straighten up the angle, right? So this angle will get straightened up. This will allow the fecal material to pass to the internal and external anal sphincters. So the mechanisms of defecation, I have already mentioned much of them, but I'll repeat from the beginning. So first of all, we have the posture and the anorectal angle. So while standing, the puborectalis muscle and the sphincters remain contracted. While sitting or squatting, this will relax the puborectalis muscle and will straighten the anorectal angle, allowing for more easier passage of the stool content. Now, secondly, we have the Valsalva maneuver. Pretty sure that you guys have taken this maneuver in the CVP block, but basically it's a forceful expiration against closed airway. That means the main thing that happens in the Valsalva maneuver is the increase in the abdominal pressure. And the increase in the abdominal pressure will facilitate the process of defecation. And actually, we all do this maneuver, and especially when we are constipated. Tamam? Lastly, we have the defecation reflex. As we have mentioned, the defecation reflex is triggered by the rectal distension. The internal anal sphincter will relaxes. The external one will voluntarily relaxes whenever it's convenient. We also have the puborectalis muscle. It will also relaxes, and this will straighten the anorectal angle. Now, this is a summary. As we have mentioned, we have the mass movements. We said that the mass movements are triggered by meals. Now, when there is mass movements, the mass movements will push the material all the way to the rectum, right? And rectal distension will initiate 3 things. First of all, the internal anal sphincter will relaxes, the external anal sphincter will contracts, and the rectum, as well as some part of the sigmoid colon, will contracts. So 3 things. Now, whenever the defecation process is convenient at this moment of time, there will be relaxation of the external anal sphincter as well as the puborectalis muscle. If the defecation process cannot happen, there will be contraction of the external anal sphincter as well as the puborectalis muscle. Now, some slides, the doctor have added them throughout the presentation. I thought that explaining them at the end will make the flow better, but they are important anyway. So the first slide, this slide talks about the relationship between the dietary fibers and the chronic transit time. So as you can see here, the x-axis, the x-axis represents the average daily stool. The y-axis represents the transit time in the colon, right? And we have those black dots. So the black dots represent the individual who are consuming the low fiber diet, while the white dots are representing the individuals who are consuming the high fiber diet. Tamam? So as you can see here, as the stool weight increases due to the high fiber intake, this will lessen the clonic transit time. So increasing the fibers in our diet will mainly decreases the clonic transit time. And this is very beneficial. I'll explain why in the next slide. And actually, for patients who are constipated, they are usually advised to eat more salads, right? This will lessens their, will elevate their symptoms. It will also promote some regular bowel movements. Now, this slide talks about the clonic fermentation. Now, there are some bacteria in our gut that ferments mainly carbohydrate. They depend on the carbohydrate fermentation. And this carbohydrate fermentation will produce gases as well as some short-chain fatty acids. Those short-chain fatty acids are beneficial to us. If the transit time of the colon increases, this will deplete carbohydrates. And this will shift the fermentation from carbohydrate fermentation to protein fermentation. Now, protein fermentation will also give me some shorter-chain fatty acids, however, in less amounts. But the thing here is that it's going to give me toxic byproducts. So those toxic metabolites, as well as this very nasty smell, right? So it's mainly a result of the protein fermentation. Now, remember, if we increase the fibers in our diet, this will mainly lessen the clonic transit time. It will increase the stool bulk. It will also promote the growth of healthy microbiota. And here we have the intestinal sodium transporters. We have this transporter. It's located on the luminal side of the intestine. Its main job is to pump sodium from the lumen into the cell. Now, there is one rule, you guys have to remember this throughout all your life. Whenever there is sodium, water follows it. So water always follows sodium. So if we are pumping sodium from the lumen into the cell, that means that we are absorbing water into the cell also, right? And you have to know, guys, that this transporter is mediated by the aldosterone. This hormone is released during time of low blood pressure mainly. You have taken this hormone in the renal block, I guess. But anyway, as I have mentioned, you have to know that this transporter is regulated by aldosterone. So when the aldosterone is secreted, it will increase the number of transporters present on this side. Tamam? Now, the aldosterone will also stimulate another transporter located on the other side of the cell, which is called the NAK-ATPase. And this transporter will pump sodium into the interstitium while exchanging it for potassium. Now, the driving force for this is the electrochemical gradient. Now, you have probably studied the sphincters in another anatomy lectures. But anyways, each of those sphincters basically has very unique role in controlling the flow of the GI content, in preventing the some damage or infection, also promote the proper digestion. Now, at the end of the GI tract, we have taken the internal and the external anal sphincters, and those sphincters work together to promote the continence or the accommodation, and will allow for the defecation process to happen. That's it, guys. I hope you have benefited, and if you have any question, please contact me. Thank you for watching.